So thank you very much. The last but not least speaker is Dr. Fredric Pieracci from Denver. He's a trauma surgeon, but he's also a thoracic surgeon. I'm sure will bring a unique perspective to what we are used to know ourselves. Thank you very much for being here.
Okay, thank you very much, Marco and Jose, for the kind invitation to present here. As mentioned, I'm a trauma surgeon from Denver, Colorado, and as an American trauma surgeon, I don't have the opportunity to make it to many thoracic meetings, and I was thinking about it this morning, and this may be the first thoracic meeting I have been to in my career, so I appreciate the invitation and the opportunity to learn from you all. Here are my disclosures. So I work at a Denver Health Medical Center in Denver, and many of you have probably been to Denver, but it's known for two things. Colorado has wonderful skiing, and we've recently legalized marijuana and became the first American city to have more marijuana dispensaries than Starbucks. I have been fortunate enough to train under the mentorship of Gene Moore, who is a trauma surgeon, but I've had many influential thoracic surgery mentors along my career, most notably John Mitchell, who's at the University of Colorado. And I, in fact, did my residency in New York City and rotated on the thoracic surgery service at Memorial Sloan Kettering and scrubbed a few cases with Dr. Baines, and never would have thought in my wildest dreams that I'd be on a panel with him at some point. I'd like to take the next 8 or 9 minutes to briefly discuss the optimal timing of surgical stabilization of rib fractures. We'll talk about a couple theoretical considerations. I'll present some data that we published in the Journal of Trauma, which is a multi-center study looking at timing of rib fixation, and then I'll end with a recommendation, which I'm happy to debate. So I'd like to make a distinction, which I think is of practical relevance when we're approaching a patient with a severe chest wall injury. And the distinction is between patients in whom we've decided that we are going to repair the ribs surgically, but we really are delaying for other physiologic reasons. So the decision to do the rib repair has already been made, but we need to figure out when the best time is. The second patient is the so-called trial of non-operative management, where a patient will come in with a chest wall injury and we'll say, oh, we're not sure if the patient's going to benefit or not from surgery. We're going to watch and see how they do. And these variable periods of non-operative management in length and duration and the treatment itself, I think, are highly variable in the literature. So if we figured out we want to repair the ribs, what are some contraindications to doing immediate surgery? And I've listed, I think, the 5 most common and important ones here. So obviously, if we have a patient who's physiologically unstable, if they're in shock, we don't want to take them to the operating room and repair their ribs. There are higher priority injuries that are frequently encountered in a blunt polytrauma patient, and most commonly it would be an unstable spine or pelvic fracture or an aortic tear that should clearly be dealt with prior to fixing the ribs. Any patient who has a traumatic brain injury and intracranial hypertension, you probably shouldn't be fixing the ribs anyway, but if you're going to fix the ribs, you certainly want to wait until the intracranial hypertension has resolved. Patients with open rib fractures are a group that I'm interested in, and it's unclear whether or not we should put hardware on open rib fractures, but at least for now, I think it's probably a contraindication to surgery. And then one that comes up not infrequently for us is an inability to position the patient appropriately. So my practice, like many of yours, I'm sure, has evolved into making incisions and positioning patients based on the location of the fractures. For example, posterior fractures, I'll position patients prone and approach that way. And if they have a pelvic X-fix on or something of the like, we just simply can't position them the way we want to. So those are the patients in whom we've decided we want to fix the ribs, but we just can't yet. Now let's talk about the trial of non-operative management. So the goal here, again, is to identify a patient who either deteriorates or fails to improve on maximal non-operative therapy. And the other idea is that certain patients and fracture series worsen over time. And I think we're just really starting to understand that a CAT scan of rib fractures that occurs soon after injury and admission is really just a snapshot in time. And a lot of those fractures, of course, they're dynamic with respiration, so they become worse over time. So many of us have probably seen a case like this of very minimally displaced fractures, which over time evolve into severe displacement. However, we don't want to wait too long before we make the decision that the patient is failing non-operative therapy, because unlike putting a femur fracture in a splint, the fractures move with respiration, and there's an opportunity cost of delaying the surgery in terms of pain, atelectasis, failure to clear secretions, pneumonia, and then ultimately respiratory failure. And there's another consideration, which is that tissue inflammation and edema probably peaks around day 3 to 5, and then much further after that, after a week or so, you start to get some callus formation, which can make the surgery more technically difficult. So really, we're looking at a spectrum here of the optimal time where you want to resuscitate the patient, and during the initial resuscitation, you're not going to perform the surgery, but you want to get the surgery done before you've missed the window and pulmonary complications are occurring. So what does the literature tell us about the optimal time of rib fixation? Here are the 4 prospective studies to date, and I was excited to learn while I was here of a French multi-center study of rib fixation and many other ones that are occurring, so I think this slide will most certainly need to be updated even within a year or two. But at least as we stand right now, you can see the 4 prospective studies, and we did one of them a couple years ago in the US at our institution. But you can see a trend towards fixing fractures earlier. The Tanaka study, which was the first of its kind, waited a week to fix the fractures all the way to 2 days median time from injury to fracture fixation in our study. Consensus statements don't really give strong recommendations as to the optimal timing. The Chest Wall Injury Society that you heard John speak of came out with a consensus statement a couple of years ago, and all we were able to say was that SSRF should take place within 72 hours of injury. We really based that on really no data. It was a grade D recommendation of expert opinion only. So we sought to bring some clarity to this issue in a multi-center study that we did in the US, now published about a year ago and presented at the AAST, a trauma meeting, as a plenary paper. And what we did is we took 5 high-volume rib fixation centers in the US, and we separated patients by tertiles into 3 groups. The first was an early group that had their surgery within a day of injury, the second 1 to 2 days after injury, and then the final group between 3 and 10 days after injury. This is a graph of the most common period in which the patient underwent repair as a function of time. It was a 10-year retrospective study. And what you can see is that there was a clear shift, which is also noted in the literature that I presented before, from late to early fixation. So the most common window in which the surgery was performed in 2006 was the late window between 3 and 10 days after injury. Contrast that to 2016, in which the majority of cases were performed within 24 hours of injury. And I would argue that these 5 high-volume centers are not necessarily indicative of what's going on around the world, but you can see the histogram here of days to surgery as a function of timing of injury, and by far the largest bar was done on the first day after injury. When we retrospectively compared these 3 groups, the first thing that we worried about was that there would be some confounding variables, meaning the sicker patients would take more time to get into the OR. But surprisingly, there were not great differences in severity of injury as measured by both ISS and GCS. The rib fracture patterns were similar. The associated thoracic injuries were similar, including the degree of pulmonary contusion, clavicle, scapula, and spine fractures. One of our secondary hypotheses was that if we did the surgery within 24 hours of injury, it would be easier technically, and our surrogate marker of this was the length of surgery. And we, in fact, did notice that surgery in the early and mid windows within a day or 2 of injury took less time as compared to surgery done later. And this was statistically significant. And here's the kind of cut to the chase slide, which is we controlled for some confounding variables using multivariable logistic regression and showed that as compared to the later window, both the early and mid windows were associated with a decreased risk of pneumonia, mechanical ventilation, and tracheostomy. It was nice to see this same question asked more recently by a group of surgeons in the UK, and I wonder if any of you are at this conference. But basically, this study was published a few months ago and grouped patients using 48 hours after injury as compared to the 3 groupings that we used in our study. But similar results were observed in that the patients who underwent repair within 48 hours of injury fared better than those who underwent repair after 48 hours. At Denver Health Medical Center, we've created a practice management guideline, and we've based the decision to perform rib repair on a clinical score, which we've termed the SCARF score. And these data are in press in the Journal of Trauma, but the SCARF score stands for the serial clinical assessment of respiratory function, and it's a 4-point clinical score, and you can see the variables included there, including IS, your ability to cough, your respiratory rate, and your numeric pain score. And I think in practicality, we all use some sort of clinical score to figure out how a patient is responding to their rib fractures. We simply quantified it into this SCARF score. So any patient with 3 or more displaced fractures gets the score calculated, and if their score is 2 or more, we'll employ some sort of local regional anesthesia, and then we'll reassess the patient, but quickly, within 12 hours of the implementation of that local regional anesthesia. And if at that time their score remains 2 or greater, we'll offer them surgery. And this whole process is intended to take less than 24 hours, and it's dependent upon having in-house availability to do local regional anesthesia around the clock, and also operating room availability and surgeons to do the surgery. So there's certainly some practical considerations. Finally, I'd like to bring up this concept of ED to OR, and the idea here is that certain patients with severe rib fractures and no other serious associated injuries may benefit from going immediately from the from the emergency room to the operating room without delay. So the sequence here, and we've done it in about 15 patients at our hospital, is that a patient will come in with a chest wall injury. They'll have their primary and secondary surgery. They'll go and get their imaging. We'll review the scans. They'll get parked back in the emergency department. We'll make sure we have an OR available, and we'll transport the patient directly to the operating room. One of the main benefits to this approach that we've observed is that if the patient has a hemopneumothorax, which is not uncommon with a severe chest wall injury, we can obviate the need to put a chest tube in the ER. And at least at our hospital, chest tube insertion in the ER is fraught with pain for the patient, pain for the attendings who are watching the ER put the chest tube in, and some sterility concerns. So to put a nice guided chest tube in under VATS in the OR as a first pass at it, I think has really been a patient satisfier. And in this way, we don't have to subject the patient to any trial of non-operative management and so forth. So to finish up, current data suggests that earlier rib repair is better, although we don't have a strict time points. I would suggest that it's somewhere between 24 and 48 hours after injury. This has been a clear paradigm shift as compared to 10 years ago, where I think the median time after injury to rib repair would be at least a week. I would advocate for an early assessment of stability and contraindications and a very brief trial of non-operative management. I think that prolonged trials, 5, 6, 7 days, you've missed all the potential benefit of repairing the ribs in the first place, and the patient has been sitting around for a week accumulating secretions, in pain, and probably has pneumonia. We've already heard a couple times about the Chest Wall Injury Society. I had the pleasure and fortune of being the second president of the society, recently stepped down a few months ago. But as the society stands, we have about 220 members. 15% or so are thoracic surgeons. My favorite thing about the society is that we have trauma, thoracic, and orthopedic surgeons now in conjunction with anesthesiologists, physical therapists, and respiratory therapists. Anyone who has an interest in the rib fracture patient, getting together and talking things out. And I think 360 days out of the year, I live in my trauma silo, and I always learn something talking to thoracic surgeons, and I hope that the feeling is mutual. And this multidisciplinary society, I think, is a great way to advance the field. Thank you again for your attention. It's been a pleasure to be here.